Hi there, my name is Angela Rishvader. This is my first recording of my podcast, which is OT at Home, but I thought I'd also record it for people who don't listen to podcasts. Perhaps you're watching this on YouTube. I recently started listening to podcasts within the last year and found a couple great occupational therapy ones out there that I found really interesting. And so I decided to create one of my own since I provide home care and have for 5 years. And I decided that it has been something that has kept my interest and passion the longest, although it is a very challenging field and it's not suited for everybody. But I decided that podcasts can be very informative, as can YouTube channels. And so when I first started OT in the home, I had no idea what I was getting into or how to go about providing the service. So my goal here is to give some information to people who might be interested. And this podcast is going to be all about placement and settings and optimal settings for patients. And I'll be sharing some experiences, and sometimes it can be a real challenge. So I found this to be a useful topic for this podcast, and I thought I would record it here as well. So stay tuned. I'm going to be hitting record here on my computer in 1 second. That's going to go into the podcast, and you get to watch me record my podcast. I'm a new podcaster, by the way, so I learned how to do it recently, and it's been a lot of fun. I love it. So, all right, give me 1 second. Here we go. I'm recording now. So in home care, we often come across things that can be a big surprise. And I just want to give my most recent experience in this situation. So I came upon a patient that was a new patient for me. So I was doing the first assessment, and funny story, should have been big red flag. And it really didn't occur to me till after the fact. I was walking up to the home. It was a trailer, and there was 4 large steps to enter. And I actually sort of fell going into the home because one of the steps had broken and it was only a half of the width of the step. So I'm, got my backpack on and I'm carrying my computer and I wasn't really paying attention. And as I'm going up and I hit that third half step, I go through and, no major injuries. It was fine, but it was a little jarring. And that should have been to me like, oh, this is not, probably safe, since the patient I was seeing had a compromised spinal cord. It did occur to me when I got to the door, how did this person get inside here recently? They'd been home 4 or 5 days. So what I want to share here is knowing how to reach out to your resources in your community when you come across a patient who you're like, wow, this person shouldn't be living here. This is not safe. What do I do? And it can be a little confusing knowing the best approach. And so I found myself in this situation, and I probably could have even done it better in retrospect, but I want to share this kind of scenario with you. So you get to a patient's home, you're doing their evaluation. In this case, it was a new patient, like I said, and she's waiting for me. She, without giving too much information, she basically had a compromised spinal cord due to spinal stenosis with a very quickly declining neuromuscular situation, right? So her spinal cord is very close to being severely compromised. And she was discharged from the hospital. She had gone in with severe pain and was discharged home on a fentanyl patch. That was the solution. Her living situation is a inconsistent son who is there sometimes and then is at work other times. The financial situation is very limited. The housing situation is less than ideal. And upon my first impression with this patient, it was like, okay, yes, the stairs situation, that wasn't so great. You walk in, the living situation was not ideal, but we come across that a lot, right? So I start going through the questions and I evaluate her upper extremity strength, and I see weaknesses there. Ask about her daily routine. As I've shared in previous podcasts, you've got to do some investigative questioning to really get the whole story. And these are where the little red flags start coming out. I had arrived for the evaluation about 3:30. And I had asked the patient at that point, so did you eat today? What did you eat? Well, they hadn't eaten, but they'd been awake all day. This is also a patient who should be testing their blood sugar and taking insulin 4 times a day. And it's 3:30 and she hadn't done that yet. So couple red flags right there. Nobody's home to assist her. When I assessed her mobility by just saying, hey, how about you show me your bedroom? Let's take a walk back to your bedroom. She was hesitant. Well, it's a real mess back there. That's okay. I'll help you clean up if you need to. Let's just get back there and let me see. So this is after I had spent some time sitting, on the couch and talking with her. And obviously there's tremor issues. She had shared with me she had a lot of pain in her lower extremities, at times, in her words, a 30 out of 10 on the pain rating scale. While we were talking, she had a little bit of a cough, like maybe 2 or 3 coughs. Those coughs caused her to shoot tears of pain out. I mean, she was like in such agony because when she coughed, obviously the compression in the spinal cord causes this nerve pain to go right down both legs. Big red flag, right? What if you're standing and you cough? What would happen, right? She's gonna fall because her hands come away from her walker. Her legs are probably gonna give out. Anyway, I'm making a mental note of these things. We walk back to her room and she almost fell twice due to weakness. Just almost lost her balance. One of her legs gave out. Her hand was tremoring. And at that point, I'm walking with her. Contact guard assist all the way back into the bedroom. And I ask her, my goodness, have you fallen? Which is a question we were supposed to ask at every visit. And she reports, yes, she fell twice that day and once the day before. This is a problem. That has to get reported to the doctor. If a patient falls, you have to fill out an incident report, report it to the doctor. So I have that already. I've got the blood sugar and insulin issue already. The pain, right? 3 areas here that need to be reported to the doctor. And I've only been there for 30 minutes or less. So we get to the bedroom and then I see all types of hazardous situations. So beyond the uncleanliness, her inability to get her legs up into the bed, the pain, there were so many things. And then you have to think, okay, what if there's an emergency and she has to get out of the house? How is she going to get down those 4 stairs? That's not safe. I asked her how she got in and she said that her son had to help her a lot. Well, that was before the step broke. So there's all types of things here, right? So I spend my time with her and I explain to her that I feel very concerned for her safety and I asked her what I can do. She said, gave me a couple things like, well, I could use a snack and there wasn't anything in the house to eat. So that's upsetting. I helped her take her meds. So these are the immediates, right? I said, okay, we need to take your medications. You need to at least have like some crackers or something. Let's check your blood sugar and make sure that you can get your insulin injected, which she did for me. But at that point, her blood sugar was well over 400 and she hadn't eaten anything all day, but she also hadn't taken her insulin. It was just all these problems, right? So I complete my evaluation. I tell her, okay, I'm going to need to call the doctor. And I explain to her, this living situation isn't the best. What do you think about that? And she totally agreed. And she said, I really wanted to go live somewhere. I wanted to be in an assisted living, but I don't think I can afford it. I don't have anywhere else to go. I'd be okay if they put me in a nursing home. She started crying. She said that she felt very alone and scared, that her pain was significant, especially when she walks. She's afraid to walk. She said she was afraid to put her feet on the ground. Okay, so in retrospect, I probably should have right then called the ambulance and said, patient not safe to be at home and needs to go into the hospital, right? Unable to manage. But because she was able to walk back there with me and get her legs up in the bed and then she was comfortable, I said, okay, I talked to her about her options. And then I said, well, I'm going to do this. I need to call Adult Protective Services. And it's not because they're going to come here and, get your son in trouble, because it sounds bad, right? Adult Protective Services, it sounds like you're turning somebody in, and that can happen. So Adult Protective Services is their function, their purpose is to provide assistance for adults, like older adults and people with developmental disabilities, in cases of neglect, abuse, but it's also for if they just need more support than they currently have in their living environment. And Adult Protective Services helps to get those things going at a faster rate. If that means that the person needs to be moved to a different place, they help get that process going. So I talked to her about that, but she said, "Oh, please, I don't want my son to get in trouble." And I explained that he wouldn't get in trouble because it's not that he was neglecting her. He had to be at work certain times of the day, and her condition had dramatically deteriorated within the last 48 hours. So my next course of action was immediately call the doctor. So I got in my car, I called the doctor. I requested to speak with the nurse, which I did. She took all the information down that I was sharing. I said, does your office have a care manager or a social worker that we could work with to get things moving? Because this person needs to be placed in a facility like yesterday. And so this office did happen to have a social worker and a care manager, and they work together. And so that is a really great thing. Not all doctors' offices have that, but if it's a gerontology office, they should have a care manager and a social worker. So that was around 4:30 in the afternoon. By 9 a.m. the next morning, the care manager called me back, and we went through all the concerning issues. In the meantime, I'm sending case communication through our digital, we have online, that's how I do my documentation. I'm communicating with my team, which consists of the physical therapist who was just there the day before, but she had declined a lot in one day. The nurse and my team leader, or my manager, as well as her manager. So everybody's aware. This is what's happening. This is how I found the patient. This is what I did. I called the doctor. I'm waiting to hear back on from the care manager. By 9 a.m., care manager calls. We come up with a plan, which was, she said, I'm going to get my social worker involved right away, and I want to talk to the nurse to get the clinical picture. So then I communicate with the nurse who's seeing the patient, and just kind of make all these connections, right? As the occupational therapist, you're there to maximize a person's independence and safety. Well, sometimes that's going to be, this whole situation is not safe. So you got to get out of here, right? And it's heartbreaking. Some patients refuse to leave the home. And what are you going to do if they absolutely refuse to leave the home, that they refuse to go to assisted living? All I can do is reach out and ask for help from Adult Protective Services, care managers, social workers. But in this lady's case, she was willing to go. So now it's a matter of how quickly can we get her there? And what ended up happening was the nurse, because of the situation, our agency nurse went out first thing in the morning. She had talked to the care manager through the gerontology office. And at her visit, she ended up deciding that she needed to call the ambulance and have the patient go directly back to the hospital, because that was the safest route. From the hospital, they would be able to hopefully admit her. And from the admission status, she could be then admitted to short-term rehab or even long-term care. But that's the course of action. In our system right now, this is just what happens. If a person is in need of immediate placement and they're unable to care for themselves, or they're unable to be cared for appropriately by their caregivers, they have to go back to the emergency room. And then that staff helps to place them where they need to go. Then the social workers in the hospital take over. So as the occupational therapist, in this scenario, I found the patient like that on my first visit. And like I said, thinking back, I probably should have called the ambulance and been like, I need to have this person go right now because she's not safe. But before calling, I don't call. So I should back up and say, when that's going to happen, you first have to call the doctor anyway. So I did that. I called the doctor. I told them the situation. I spoke with the nurse. She did not tell me on the phone, call the ambulance and have them take her back to the hospital. So I didn't. I could have recommended it, but I thought, well, let's see, if we can work this out. But this is what ended up happening with this patient is that she made it through the night. To my knowledge, she didn't have any more falls. And she did end up going to the hospital the next day. And from there, let's hope she gets placed appropriately. But what happens in home care often is that we come upon patients, and I think this is going to be happening, unfortunately, more and more. Patients are getting discharged to home very quickly from all types of admission statuses or observation statuses. Many patients will go into the emergency room for a situation. They're there for 24 hours or less, and they're discharged to home. And as the in-home provider, it's our responsibility to recognize the dangers and figure out what to do. You're not on your own with that. You just need to know who to reach out to. And so recapping, it's always doctor first, right? Then your team, communicating with the team, everything that's going on, getting everybody's involvement from the beginning. You've got to show that you're working as with an interdisciplinary approach. And you've got to know your resources. So had things gone differently, or had I not been able to work with a care manager in the doctor's office, I would have called Adult Protective Services myself. All I have to do is make a referral, give the information, give them my concerns, and then they have their people directly interact with that patient and go from there. But I was fortunate enough to be working with a doctor's office that had better resources. So that worked out really well. You just have to know which way to go. Anyone can find your Adult Protective Services local number by looking that up. It varies, obviously, by county. And just having that information and knowing how to report the necessary information and knowing what makes it appropriate to call Adult Protective Services. So let's think about that for 1 second. If I have an individual of any age, an adult, whatever the situation is, at home without the ability to exit the home safely, if they cannot answer the door to let somebody in, those are big red flags, because that person is unable to get out of the house. They're unable to, obviously get up and get what they need, which would include food, medication, toileting. These are the basics. Some less pressing red flags would be a flea-infested home where a patient cannot manage the disinfection. So let's say that, the dog or the cat, they need to be bathed. They're full of fleas and there's fleas all over the home. How is this person with a disability of whatever form, deconditioning, how are they going to manage that? That requires reaching out to a different group of people, like Adult Protective, and say, listen, this person, they're doing the best they can, but they can't manage this, right? Let's imagine you go into a home in the summer and it's blazing hot and there's no fans and there's no air conditioning and the person has no way of, cooling themselves down. Is there a routine or a method that you could come up with to help with that? If there is, great. But if it's a real safety risk, you need to notify the doctor and then consider reaching out for additional support, which could be your Office of the Aging. They may have solutions, but Adult Protective Services, I think, is often, I know I used to kind of cringe at the thought of calling that, like, oh, it's going to mean that the person's taken out of their home and whisked off to a nursing home and their family members are going to get in trouble. But really what they're there for is to advocate for the safety of the patient, because our aging population does not have a sufficient voice for themselves. They really don't. It's very unfortunate. That's what we are as home care providers of all types. If you're an OT or a PT or a nurse, you are to be focusing on the person's safety, independence, and to advocate for them. Sometimes you got to do things that seem kind of off, like calling, adult protective or getting people involved. But at the same time, it's a huge blessing. So in this case, my patient was really wanting to get out of her living situation, but she just didn't have the way to do it. I've heard from some of my other teammates that sometimes if a person needs to be removed from a living situation and there's no room at the adult protective assisted living or nursing home, then adult protective can temporarily put them like in a motel to be cared for with aides. Like there's different options. And so they work that out. Here's the other thing, knowing what is best placement, right? So the care manager and I spoke in regard to this patient on the phone, and she asked me, well, can she transfer herself? Now, technically the patient can transfer herself, but could she transfer safely in a manner that an assisted living facility would accept? No, she didn't. It was not a safe transfer. She would get up and, like I said, if she coughed or something, she would fall. She had already fallen twice. She had neurological changes in her legs. So she had like a kind of bouncing effect on one side. The other side would occasionally give out. She couldn't feel on one leg from the knee down. She was an unsafe ambulator and an unsafe transferring person. So that's not appropriate for assisted living. That means that she's more long-term care placement. And they need us to help with those decisions, knowing what setting is going to serve this person best. In assisted living, you've got to be able to transfer, toilet, manage your incontinence. You've got to be able to get yourself to meals. And depending on the setting, you need to be able to ask for like your PRN medications. Some medications you may take on your own. Usually they're passed, but you have to be able to get to your dining room via wheelchair or ambulation. But if it's a wheelchair, you have to get yourself there and do all your transfers. So that's quite a lot of mobility that is required for that. And so we have to keep that in mind. I wish there was an in-between. I wish there was a higher level of assisted living. There is in some scenarios, there's higher level assisted living facilities where they offer more assistance as far as assisting with transfers and assisting with dressing. But it's not consistent is what I'm finding. So these are my tips on knowing placement for your patients, what's best, and who to reach out to when you come across a patient that should not be at home. What do you do? It's not all up to you, and you just got to remember to connect with your team. Your first resource is always going to be the doctor. That is who is signing your orders. That is who you are answering to. In the end, you're making sure you're working with that doctor's office. If they're unable to facilitate the action that needs to take place, then it's Adult Protective Services. If it's an immediate situation, this person is not safe at home, they right now need to, be somewhere else, you're calling 911 and you're having the ambulance come out and pick this person up and take them back to the hospital. And that's that. So that was my scenario this last week. I just thought it was one of those things where 5 years ago, I would have been like, oh my gosh, what am I going to do? And it's happened enough times now that I know the process. But like I said, even now, I'm like, well, I should have probably had her leave even sooner, but I did follow what the doctor's recommendations were. And so I'm covered in that respect. And in the end, the patient ended up getting the care that she needed, which was great because we worked as a team. And that's what home care is all about. So sometimes people will go into home care thinking, oh, it's all this autonomy and I can do all my stuff on your own. Well, you're walking into that house all on your own. That is for sure. But you can't be making decisions all on your own. You've got to be working with your team, the doctor's office, and thinking on a much bigger scale. But you've got to be thinking critically and really being able to put into place what your specialty is. So as an occupational therapist, your specialty should be in maximizing independence, safety, and assessing a person's ability to manage their basic ADLs and self-care. That's where it all starts. There's a whole lot of other things that we do, but really that's why we're called in there. So when you see things that are like, wow, this isn't safe, and there's no way that this person's going to be able to manage taking over this and improving this area of self-care or ADL safely, it's just not a rehabable situation. Guess what? It's time to call in some additional supports. So that's all I have for you on that. I hope it was helpful, and you'll be seeing and hearing from me on other topics. So stay tuned, and I appreciate all your tuning in, and I look forward to hearing if you liked this. If you would subscribe, that'd be awesome. That helps more people hear these tips and get feedback maybe and brainstorm some ideas. If you are on YouTube, obviously you could subscribe to this channel. If you like it, go on over to Apple iTunes and subscribe there and leave a comment. I would love to hear your comments and feedback. It really helps. The more people review and subscribe, more people know about it. So I am thinking that as we progress through some big medical changes, there's going to be a huge need for home-based OT. And if we can get more people to be less weary about it, that would be great, because that's what's going to really support our medical system. And if there's more of us out there, we help each other out. And that's what this is all about. So thanks for listening. And I hope to hear from somebody and get some new subscribers, and we'll keep each other informed, right? Stay safe out there. Thank you.